So, Assalamu alaikum
Assalamu alaikum.
everyone. I'm Aisha Zulfikar, and I warmly welcome all of you on behalf of Giving Back to Pharmacy Pakistan. And today our topic is Pulmonary Disorders, Gout, and Adult Immunization, which will be presented are our respectable faculty member Abdul Haq Khan. He is currently working as a pharmacist at NMC Royal Hospital, Khalifa City, Abu Dhabi. Before this, he has worked with Lifeline Hospital, Dubai as a narcotics in charge pharmacist. He did his BCPS certification in 2020, and he has earned CPHQ certification last year, 2021. Thank you so much, sir, for giving us your valuable time. It's over to you.
Assalamu alaikum everyone. Thank you so much for arranging this wonderful session and wonderful series to all members of Giving Back to Pharmacy in Pakistan. So let's start our today's topic. Our topic is pulmonary disorders, gout, and immunization. Before starting my presentation, I have not received any financial or commercial funding or support for today's session, and I will not discuss any off-label use or investigational use in my presentation. I will discuss the following off-label use or investigational use in my presentation. Okay. Next, learning objectives. First, our learning objectives is accurately classify patients, assess, control, and select and monitor treatment for pediatric and adult patient with asthma, and for adult patient with chronic obstructive pulmonary disease COPD, incorporating patient-specific factors. Secondly, we will discuss apparently assess, classify, and select pharmacotherapy, acute and chronic, including non-pharmacologic therapy, and monitor, reassess, and adjust pharmacotherapy in patients with gout. Lastly, we will discuss determine appropriate immunization for an adult given his or her age and medical conditions, and correctly apply cautions, contraindications, and drug interaction with immunization to adult patients. Here, we will discuss three objectives: gout, pulmonary disorder, gout, and adult immunization. Let's start our first topic, asthma. When we talk about asthma, on the basis of characteristics and symptoms, many times we can confuse asthma and COPD. So there are four characteristics: cough timing, FEV1 reversibility, and triggers. In these four characteristics, we can divide asthma and COPD and diagnose correctly. And asthma cough will be non-productive, while in COPD it will be productive. And cough timing in asthma will be worst at night or early morning, while in COPD it will be throughout the day. FEV1 reversibility in asthma will be 12% improvement after short-acting beta agonist, while in COPD, even after use of short-acting beta agonist, it will be irreversible. In asthma, triggers are allergic and environment, while in COPD, history of smoking we will find if you take the history of patient. Next. Here, some criteria parameters on the basis of which we can differentiate asthma and COPD, many parameters. And among of them, if three or more features are we are finding in asthma section, then we can say that patient is suffering with asthma. And if more than three or more features we are finding in patient with COPD, then we can diagnose COPD. Later on slides, we will discuss in details this topic also. And if equal number of features we are finding, then it will be asthma COPD overlap syndrome that we will discuss in our further slides. Next. So here asthma we can classify into four categories: intermittent, mild persistent, moderate persistent, and severe persistent, only on the basis of some symptoms, night awakenings, beta agonist use, and interference and lung function. In intermittent, the symptoms will be less than 2 days per week, while in mild persistent, it will be 2 days per week, but not daily. And in moderate persistent, it will be daily, and in severe persistent, it will be throughout the day. And the most important is night awakenings. In intermittent, it will be less than 2 days per month, while in mild persistent, it will be 3 to 4 days, while in moderate persistent, it will be once a week. Here, you have to just focus. In the mild, intermittent and mild, we are saying per month, but now in moderate persistent, it's coming like per week. So when we are classifying in our question section, then we have to take care about this. While in severe persistent, it will be often or 7 times per week, throughout the week, you can say. Same in beta agonist use, we can see how the difference and interference with the daily activity in intermittent, none, mild persistent, minor, moderate persistent, some, and severe persistent, extreme. And one more, in the down, you can see steps are showing step 1, step 2, step 3, or 4, 5. Here, when we are in, we will discuss on our further slides. Just try to remember these things. Our next slide is assessing on the basis of control. When we start the therapy of our patient, on the basis of control, we decide either it is well controlled, not controlled, or very poorly controlled. And then what data we collect, on the basis of this data, then we decide that either we have to step down the therapy or step up the therapy. What we have to do. Here you can see if we started the therapy, and suppose patients before was complaining about less than 2 days, now it is more than 2 days, then we will see this now patient shift to well controlled zone to not well controlled zone. Then we can step up the therapy. What does it mean step up the therapy? We will see further. Next. Here are the steps. We are discussing about the more than 12 page step of therapy. Here are 6 steps we can see. On the first step, we can say this it will be intermittent asthma, that relieve with the use of short-acting beta agonist as needed basis. If it does not relieve, then we can say the patient is on step 2, and we can start with low dose inhaled corticosteroid or leukotriene modifier or theophylline or cromolyn NABs. Step 3, if patient not getting relief, then we can say patient is suffering from step 3. Then we can start add up, including ICS, we can add LABA or medium dose inhaled corticosteroid. This slide is very important as per BCPS or ambulatory care exam prospectus. If you remember whatever written here, then it will be very easy for you to target your question. Same you can see step 4, 5, and 6. The step 6 you can see you can add up ICS, LABA, oral corticosteroid you can add, and tiotropium. And one more thing, just you can note down, tiotropium cannot be never used alone. It should be also always be used with inhaled corticosteroid and LABA. That's next. Here our case, 23 years old woman has been coughing and wheezing twice weekly plus 3 times per month. At night, she has never received a diagnosis of asthma and she has not been to a doctor in years. She is using her roommate's albuterol activity not limited. Spirometry FEV1 is 82% predicted, which is the best classification for asthma. See here, we can see we can know how to classify asthma. In our previous slides, we see how we are checking the class of asthma. So here, what should be our answer? Either it should be intermittent, mild persistent, moderate persistent, or severe. Can you go next slide? Yeah, here. So what will be our answer? In our previous slide, we discussed that patient is suffering night awakening 3 to 4 days in a month. So in this case, 3 times per month. So in this case, we can say our answer will be B, mild persistent. We have to memorize all the symptoms. Any one of the symptom or one or two will patient can come in the exam question, and then on that basis we have to target our question. Next. Here, next. Patient case 2. Which medication is best to recommend for the patient from case 1, mild persistent asthma that we did previously? In addition to albuterol, MD1 2 puffs every 4-6 hours as needed. No additional therapy needed. Montelukast, Parodol 10 mg daily, betamethasone, or budesonide formoterol 2 puffs BID. So as it is, can you go next? Yeah, as it is mild persistent, and can you go next? Yeah, as it is mild persistent, so we can say we can start with low dose inhaled corticosteroid. Okay, so in this case, our answer could be mometasone DPI 2 microgram 1 puff daily. You can start with low. As patient is mild case, so we can start with step 2. As patient was already using albuterol SABA, short-acting beta agonist, but he was not getting relief. So we start with step 2. Now, as we discussed in our previous slide about asthma COPD overlap syndrome, then initial therapy in this case, as I told you before, that 3 features of asthma diagnosis. So we will treat as asthma. If 3 features for COPD, then we will treat as COPD. If similar number of features for both asthma and COPD, consider ACO, asthma COPD overlap syndrome, and use inhaled corticosteroid usually at long-acting beta agonist or LAMA, long-acting muscarinic agonist. Consider both efficacy and safety. No LABA therapy if any features of asthma, and importantly, non-inhaled corticosteroid monotherapy if potential diagnosis of COPD. We will never use LABA alone if we diagnose as asthma, and we never use monotherapy if we are diagnosed as inhaled COPD. Next, please. Here, now we are classifying asthma exacerbation in urgent or emergency department settings. When we are receiving, suppose we are working in any hospital and we are receiving any patient, so in what basis we will classify in mild, moderate, severe, or life-threatening condition. This is very important. In the initial stage, we have to decide either if in mild stage, if dyspnea only, and only when the patient is lie down, he's having dyspnea, and if even over PEF is 70% or more, and heart rate is up to 100, then we can say patient is having mild class of asthma. But in case patient is dyspneic and have limited interference with usual activity, preferably while he's sitting or lying, and the heart is increased to 100 to 120, and this FEV1 and PF decreased to 40 to 69, then we can classify it to moderate. Just try to remember these all readings, because in any one of the readings will become in the exam question. Then on the basis of that reading and that value, we will classify our patient. Then on the basis of that classification, we will decide our medication and pharmacotherapy treatment. Same in life-threatening case, if patient is dyspneic and not able to speak, then we will consider is life-threatening and we will give life-threatening pharmacotherapy. Here, initial management of exacerbation of emergency or hospital condition. If mild to moderate, then oxygen to achieve 90%, inhale short-acting beta agonist up to 3 doses in first hour, oral corticosteroid if no response immediately, or if patient recently took oral corticosteroid. In severe case, oxygen we will give, and along with this, high dose inhaled short-acting beta agonist plus ipratropium. Then oral corticosteroid we will add up, and consider adjunctive therapies, IV magnesium or IV ketamine or Helox, if patient is still not responsive. And if the condition is life-threatening, then intubation or mechanical ventilation can be suggested, and nebulize with SABA plus ipratropium. So this will be our pharmacotherapy treatment when we decide, like in our previous slide, what stage of the patient is of asthma. Now we will discuss COPD, chronic obstructive pulmonary disease. On this, we diagnose first on the basis of GOLD guidelines. GOLD guidelines. These are global lung disease guidelines. Consider COPD and perform spirometry if more than 40 years old with any of the following. If patient is dyspneic, chronic cough, chronic sputum production, history of exposure to risk factor. Most common is tobacco smoke. As we discussed previously in our slide, that history, we will find history of smoking in the COPD patient. Criteria of diagnosis for COPD will be symptoms and risk factor, plus the important one is FEV1 over FEVC will be come like less than 70%. This is very important criteria for the diagnosis. As we discussed already, frequency of exacerbation will be throughout the day and 12 months. Less severe, we will consider 0 to, we will give 0.021, no hospital admission, and more severe, it will be more than 2 or more hospital admission, then we will give points. Why we are giving points, that we will discuss in our further slides. Here, there are some GOLD grades. On the basis of these grades, we identify our patient on, then only we decide our pharmacotherapy treatment. On first stage, FEV will be 80 or more, second stage 50 to 79, third stage 30 to 49, and fourth stage it will be less than 30%. And this is the very important values, just try to remember. And on these basis of, if we during our exam question, if we successfully try to figure out the GOLD grade, then it will be very easy for us how we can decide the therapy, because for every GOLD grade there will be different therapy. On first GOLD grade will be different, then there will be some addition, then there will be some addition that we will see in our further slides. So our first target is to decide and to figure out which the condition is uh, exam is telling, our question is telling, and patient is on which goal rate. Okay, so just try to remember these values. Here some validated symptom scale on the basis of we classify our patient. The most common is modified British Medical Research Council breathlessness scale, MMRC. In this only measures severity of breathlessness. Score will be 0 to 1 if less symptom, and score will be 2 or more if more symptoms. Same in COPD assessment test, also called CAT, and COPD control questionnaire. So in this we will discuss, see why we are giving these scores, because on these scores we will decide our first we will figure out what was the stage and the condition of patient, then we will finalize our pharmacotherapy. So just carefully try to remember this scores. Here, goal refine. Can you go next? Goal refined assessment of COPD severity and risk. Here, carefully just see this slide. On the left side down, you can see FEV1 predicted. Just previously we discussed gold stage 1, gold stage 2, gold stage 3, and gold stage 4. If our question, if the question is saying the patient having FEV1 stage, FEV1 value of 30 to 49, then immediately we will decide the patient is on gold stage 3. Now the second, exacerbation history past 12 months. If it is 2 or more, then the score will be different. If one score 0 or 1, then not leading to the hospital admission, then on the basis of this we will give a score. The third is assessment of symptoms, risk of exacerbation. Here A, B, C, and D, 4 categories of patient. On the basis, if suppose if patient is FEV1 30 to 49, gold stage 3, and he has not leading hospital admission. Okay, so we can see the patient is lying in category A, but A and C, sorry. But on what basis we will differentiate? Patient will either patient is from category A or C. This down MMRC, on this basis or our CAT score we will decide either patient is A or C. Okay, so try to remember this slide very carefully, because this is the most difficult slide. If you remember this slide very clearly, then it will be very easy for you in a very short time of what you are getting time for targeting one question. If you clearly remember this slide, it will be very easy for you to target the question. Here, COPD principles of pharmacotherapy. Medications for symptomatic treatment only. Some data showing fewer exacerbation, hospitalization, and improved lung function and quality of life. Long-acting bronchodilators are initial treatments. Short-acting only PRN. We already discussed that short-acting beta agonists we are using only PRN basis. If not relieving the patient, then we are going a step up and further adding up further treatment in our patients. In moderate to severe COPD, long-acting or anticholinergics are recommended over twice daily LABAs to improve exacerbations. This is very important. If in the exams they are saying patient is already taking like long-acting anticholinergics, what will be the suggested therapy? Maybe in question the one of the option is twice daily LABA. So if you remember this thing, then it will be very easy for you to solve the question. And the last one is short-acting bronchodilators in moderate to severe use. Here, short-acting muscarinic agonists are recommended over SABAs in COPD, and SABA-SAMA combination recommended over short-acting beta agonist. All the things we are discussing here will become like a chart in our further slide, so you can easily understand. Here, pharmacotherapy for COPD, as we discussed before, the stages are A, B, and C, and D. So if patient, suppose, so on stage B, so we will start LAMA or LABA, and recommended treatment will be LAMA or LABA, long-acting muscarinic agonist plus LABA. And alternatives for stage A and B, there are no alternative. What we are suggesting, the treatment, we will follow the same. Like in stage A, we will continue to try alternative class of bronchodilator. If not relieving, then we will classify our patient to stage B. Same like step C. First choice will be long-acting muscarinic agonist. If not, then we will adapt LABA. And it's still not working, then we can adapt inhaled corticosteroid, intermittent intensification. And the most severe case will be stage D. First choice will be LAMA plus LABA. If not working, then we can adapt ICS, inhaled corticosteroid. And in the most intensive condition, not working, either we can add up of LAMA or LABA, or we can add PDE4 inhibitor for in case of treatment intensification. Okay, and just try to remember, most of the time these most severe conditions cases are coming in the exam. So if you remember this most severe D stage, then it will be easy for you to remember all the stages. So try to remember this D stage very correctly. So it will be very easy to target the question. Here we have one patient case for COPD, 62-year-old woman with recent diagnosis of COPD. Here, spirometry showed FEV1 over FVC 60%, pre-bronchodilator FEV1 70% predicted, post-bronchodilator FEV1 72% predicted. Symptoms vary, both storm in MMRC grade 2. Okay, that we have discussed before also. One exacerbation in past year, but no hospitalization. Which is most appropriate gold patient group? So here just take a rest and try to recall what we discussed earlier, and on the basis of that information decide which group patient is lying. Can you go next? Asha, can you go next? Yeah. So that chart we saw before also in our question, showing spirometry FEV1 over FVC less than 60% and pre-bronchodilator 70% predicted. So in this case, if FEV1 over FV1C is showing 60%, so we discussed earlier, if in this case our stage will be B. Can you go previous slide? Here on the information given in the group, if we are clear about our information, then easily we can target our question. So we have to, again I am saying, just try to remember all the values, so it will be very easy for you to target the question. So now, how to manage COPD exacerbation? Short-acting albuterol is preferred, and here now we are discussing the pharmacotherapy. Okay, and just remember the dose also. Okay, in the exam maybe you will remember that it was giving short-acting albuterol, but maybe the dose, maybe it will show decreased dose or increased dose. So exact dose, try to memorize exactly, so it will very good for you. Same systemic corticosteroid effectiveness used in most exacerbation. Dose in outpatients 40 milligram up to 60 milligram prednisone daily for 5 days. And there is not sufficient data for using for 14 days. The same effects we are getting if we giving for 5 days. Okay. Next. Okay. Cardinal symptoms of airway infection. Three symptoms can be there. Increased dyspnea, increased sputum, increased purulence. Okay, so if all of three are present, like increased dyspnea, increased sputum volume, and increased purulence, we will say definitely it is a COPD exacerbation. And COPD exacerbation with two cardinal symptoms. One is increased sputum purulence. Okay, so one of the symptoms should be increase, and the other may be dyspnea or sputum volume and COPD. So we can say it is COPD exacerbation. And the third one, severe COPD exacerbation requiring mechanical ventilation. And if it is severe, then we will require mechanical ventilation. So in this way, we can manage our COPD exacerbation, different cardinal symptoms. Here we discuss about antibiotics for COPD exacerbation. Antibiotics, optimal antibiotics therapy actually should be based on local resistance pattern. If you are working in UK, your local resistance pattern will be different. You are working in America, their patients, their hospitals. If you go to labs and see the results and charts, you will find different patterns. If you are working in UAE, Arab countries, it will be different. So we cannot say any universal antibiotics choice. So we have to decide only on our local resistance pattern. Empiric antibiotics are used to cover the most common pathogens. This is the very important thing. We know the exact, the very exact cause of these 3-4 organisms are the most common cause of pneumonia and this COPD. So when we are suggesting our empiric antibiotic, they must be cover these strains. Okay. And in Gold 3 and 4 patients, Pseudomonas aeruginosa is the more prevalent. So recommended antibiotic what we are giving, it must be cover this strain, and the duration should be 5 to 7 days. So now we start our another topic, gout. Here presentation and predisposing factors for gout. Acute, what is gout? Acute severe arthritis, usually episodic and can be chronic. Tophi may or may not be present. Okay. Acute gouty attack. In acute gouty attack, what we see? Severe pain, redness, and swelling. Worse in first 12 to 24 hours. Continuous for few days to weeks. And third, most often in lower extremities and in a single joint. What are the predisposing factors? Diet, alcohol, drugs, xanthine oxidase inhibitors, uricosurics, diuretics, niacin, and aspirin. These are the drugs who may contribute the development of gout. And also obesity, diabetes, and other kidney related disease also we found in the history of gout patients. So we can say these are the conditions who can contribute to gout. Next. Here, classification of gout. There are three classifications: acute gouty arthritis, intercritical gout between attacks, and chronic recurrent gout. Severity of chronic tophaceous gouty atrophy can be mild, moderate, or severe. In mild, only one joint or will be involved. In moderate, 2 to 4 joints will be involved, and in severe, 4 joint will be involved, and it will be complicated. And severe articular tophi we will find in our examination, X-ray and other examination. So whenever we are talking about gout, we are actually talking about hyperuricemia, increased level of uric acid in our blood. For gouty patient, the serum urate target is minimum or less than 6 milligram per deciliter, and our goal will be maybe 5 milligram per deciliter if signs and symptoms are improved. And it can be 5 mg also if tophi is present. If tophi is not present, then the condition will be different. But if tophi is present, then we should consider more less than course to 5 mg to prevent the severity of gout. Consider discontinuation of NSAIDs, non-essential medication that cause hyperuricemia. If patient is taking some medication that we are suspecting that these are the medicine like diuretics and others we discussed earlier. If we think that without this medicine, or we can replace this medicine with suitable alternatives, so we should go for that to reduce the risk of gout. Indication for urate lowering therapy. How to start, or how we decide that we should start urate lowering therapy. TOFUS or TOFI by clinical exam or imaging study means maybe one or more TOFI are present when we did our X-ray and imaging study. And more than 2 acute gout attacks per year, chronic kidney disease stage 2 or worse, and past urolithiasis. If these conditions are present in a patient, then we can go for the indication of urate lowering therapy. What are the choices for urate lowering therapy? Urate lowering therapy can be started during an acute attack as long as concomitant anti-inflammatory therapy is given. First line, what are the first line urate lowering therapy? Xanthine oxidase inhibitor. It includes allopurinol and febuxostate. Alternative is probenecid, which is actually uricosuric. And one more important thing, you must initiate anti-inflammatory prophylaxis for acute gout concomitantly with just or prior urate lowering therapy in all patients. Why? Just to prevent the initial stage inflammation in the body when the ULT starts showing its effects in the body. So body in the response can develop some inflammation and severe pain. So we should start anti-inflammatory drugs as a prophylaxis. Early increase in acute gout attacks during initiates of ULT. Why? How this anti-inflammatory prophylaxis we will perform? First line, oral low dose colchicine. The Second one, other first line option is low dose NSAIDs. This you have to remember that we are talking about low dose, not high dose. Okay. Lower evidence. Oral corticosteroids are an alternative only if colchicine and NSAIDs are contraindicated or not tolerated or ineffective. Only in this case we can go for oral corticosteroid. Otherwise, if our condition is allow, we can go for colchicine. If condition does not allow, we will prefer NSAIDs. If both we cannot prefer due to the some conditions, then only we can go for oral corticosteroids. Again, the acute gout prophylaxis should continue for the greater of 6-month duration and 3 months after achieving target serum urate, if not high. Okay, it means we have to keep checking the uric acid or urate level. On the basis of that lab report of uric acid, we will decide our further treatment. Either it can be 6 months or 3 months, how we are getting our target. If 6 months after achieving target, urate if tophi were previously present but now resolved, then we can decide to decrease the dose or just complete our therapy. And importantly, continue prophylaxis if any clinical evidence of gout disease activity is present. Means if we are not getting any improvement in the systems, in the symptoms, then we can continue our therapy. And if patient is still getting gout attacks and chronic gouty arthritis, we can continue our therapy. During urate lowering therapy, monitor serum urate every 2 to 5 weeks. Okay, it can be every 2 weeks, 3 weeks, or 5 weeks, depend on the condition. And on that result, we will decide our goal. What should be our urate lowering goal? Then we will try to achieve. If after goal is achieved, continue monitoring every 6 months. Okay, it is very important because we cannot leave patient like this without any monitoring. So even patient has achieved the goal of urate level, so we have to call the patient for follow-up every 6 months. If serum goals are not achieved, then titrate single agent xanthine oxidase inhibitor to maximum appropriate dose. That in case of allopurinol, it can be 800 milligram per day, and doses more than 300 milligram can be used even in CKD. If patient is CKD, then we can go for 300. Otherwise, in a normal patient, we can go for 800 milligram per day if we are not getting our serum urate levels. What we can add up with this, we can add uricosuric like probenecid, losartan, or fenofibrate. Although that losartan and fenofibrate are off-label use but recommended as a second line uricosurics. Okay, but we will try our best to achieve our goal to xanthine oxidase inhibitor. If goal is still not achieved, now we will go for pegloticase if severe gout disease burden and refractory or intolerant to other ULT options. This we will do in the most severe and intensive condition. We will go for pegloticase if none of our therapy is working. And we can go for indefinite duration of urate lowering therapy. If we are not getting goals, we are not achieving, and if suppose we are achieving, then on follow-up we are checking that urate therapies, urate level is going up, so we can go for indefinite duration of urate lowering therapy. Go next. Here, treatment of gout, acute gout. initiate pharmacologic treatment within 24 hours of onset of acute gout. Once patient start experiencing gout, so within 24 hours we have to start our treatment. It can be colchicine that we discussed earlier, and it is appropriate if started within 36 hours of attack onset. This is the timing is very important. Just keep in your mind this 24 hours and this 36 hours. Which patient is coming to you and the patient is telling that he got the symptoms like last 10 hours, 12 hours, 15 hours, then we can go for colchicine at up to 36 hour. If it is not, it is more than 36 hour, then no use of colchicine. Just keep in your mind. Maybe in the question will be tricky that it will show that patient is having symptoms, but the timing will be different, and it will question will ask what will be the first line therapy. So immediately don't go for colchicine. Just try to check what duration is mentioned in the system, how many hours are mentioned, then you can select your option. Okay. Now, secondly, continue establish urate lowering therapy without interruptions during acute gout attack, and assess severity of gout attack and select treatment based on severity. Okay. In monotherapy, mild to moderate pain, one or few small joints are involved, or one or two large joints. In this case, you can use NSAIDs or oral corticosteroids or colchicine. And other supplement topical ice, like this is we can say non-pharmacological therapy as needed. No prefer for one. Select based on presentation, comorbidities. This is very important. The comorbidities, previous response, and patient preference. Sometimes patients are not compliance of one option. Suppose in case of NSAIDs, if patient is complaining about some adverse effect or something, then we can choose our therapy. And we can go for combination therapy also if severe pain or poorly articular attack or multiple joints is involved, then we can go for combination therapy. In monotherapy, when we use colchicine, if patient has received acute treatment in past 2 weeks, then go for alternate therapy. But labeling use in patient with renal or hepatic impairment taking prophylactic colchicine is not recommended. So better go for other options if patient having symptoms of hepatic or renal symptoms. And how about corticosteroid? Consider intra-articular if 1 to 2 large joints involved, and oral for all other presentations. Many times we consider IM triamcinolone followed by oral corticosteroid. So this is the pharmacotherapy. Just try to remember this series. Okay. So when we give preference over one therapy to other. Here, initial combination therapy, full doses of both agents or full dose of one polyprophylactic dose of another. Treatment options are colchicine plus NSAID. Here, just be careful when we are going for treatment options. Colchicine plus NSAID, OCS plus colchicine, intra-articular steroid with any other, and avoid combination of NSAID plus oral corticosteroid. Okay, due to gastric symptoms. So never go for a combination of NSAIDs and OCS. Although you can either you can go colchicine plus NSAIDs or oral corticosteroid plus colchicine, but never go for NSAIDs plus oral corticosteroid that may cause gastric symptom that will be not good for our patient. So here case young 60-year man with third gouty attack in past year. Last attack was 10 days ago. Okay, just keep note down the timing. What timings are giving in the question. 10 days ago, took colchicine with good response. Pain is in the left knee and third, fourth interphalangeal joint on left hand. Pain is 6/10, started about 10 hours ago. Past medical history, COPD, dyslipidemia, normal renal function, weight is 80 kg. Uric acid concentration he checked 1 month ago was 10. That was very high, but not of high. Okay. Current medication patient is taking tiotropium, albuterol, simvastatin, which is the most appropriate treatment for this acute gouty attack. Either naproxen, colchicine, intra-articular triamcinolone, or prednisolone. Just try to recall what we learned before, and the basis of that, try to answer this question. Here, when we were talking about monotherapy, in our immediately it comes in our colchicine comes in our mind. Okay, colchicine would be the option, but in question it's already mentioned that patient is having attack for 10 days, more than 10 days. So, but in colchicine, in this case, we cannot go for colchicine because it can be it is beneficial only within 36 hours. Okay, so in this case, the first our therapy could be option A, naproxen, 70/50 NSAID alone, because the option C and option D would be the next option if they are not working. Third and fourth, our choice. But first, we will try to try our second option, naproxen. Colchicine already patient is taking, so we will go for option A, naproxen. And in the naproxen also we mentioned earlier, it will be low dose. So first we will start with 750, but then we will switch to 250 milligram 8 hourly. It should be low dose. Okay. Now our final topic, third topic, is adult immunization. Adult immunization, there are some general guidelines for adult immunization that we are following. Okay. The first one is basic recommendations for immunization of adult are based on age and specific vaccines. Certain medical conditions require special consideration when determining whether additional immunization are recommended. And on the basis of patient-specific factors, specific vaccines or formulations should be avoided or used with caution. So these are the general guidelines for adult immunization we have to follow. Some contraindication and precautions are there for adult immunization. Do not administer a vaccine. This is very important. These both points are very important. Do not administer a vaccine when a contraindication is present due to an increased risk for a serious adverse reaction. Live vaccines should generally be avoided in patients that are severely immunocompromised, and pregnant women should not receive live attenuated vaccines due to theoretical risk to the fetus. In general, vaccine should be deferred if a precaution is present based on the risk of experiencing a more severe reaction to the vaccine. A vaccine can be administered when a precaution is present if the benefit outweighs the risk. If we are thinking that no, we should give vaccine and we will try to manage the adverse effects or what the harm will cause the patient, we can handle it, then we can go for vaccine. All vaccines have a precaution for administration in a patient with a moderate or severe acute illness with or without fever. So these are the general guidelines, and some major changes in previous adult immunization are because they are routinely our the different immunization schedule. The societies are routinely they are updating this schedule. So the recent one is 2020 adult immunization schedule. There are some changes they made. HPV vaccine is now recommended for all individuals through the age of 26. Shared clinical decision making should be considered for individuals between 27 to 45 years of age. Pneumococcal vaccine should be strain 13 should be administered to the immunocompetent adults 65 and older after shared decision making. And TDAP can be used when TD is indicated. So just try to remember all the things, because any one of the condition can come in our exam. Maybe it related to patient age, maybe it related to vaccine. So try to remember the age and the vaccine both. Varicella can be considered for individual with HIV without evidence of varicella immunity when CD4 counts are 2000 cells or greater. Okay, so this is the end of our presentation, and thank you so much for making this arrangement, and I'm very thankful all of you. Thank you so much.